Polycystic ovary syndrome is the most common endocrinological disorder in women of reproductive age, affecting between 4 and 8% of this population. Because of its name, the most common diagnostic trap is assuming that finding polycystic ovaries on a routine scan equals a clinical diagnosis. It does not. This ultrasound image shows the classic anatomical presentation: multiple subcapsular follicles, typically between 2 and 12 millimeters in diameter, arranged around a dense central stroma without a corpus luteum. Yet this exact ovarian morphology is observed in up to 20% of the healthy general population. Polycystic morphology is a symptom of a deeper systemic disorder. Relying on isolated anatomical imaging is insufficient for a diagnosis. The clinical criteria rely on 3 pillars: oligo or anovulation, hyperandrogenism, and polycystic ovarian morphology. Documented evidence of just 2 out of these 3 criteria is required to proceed. The hyperandrogenism component can be established either through clinical signs like severe acne and hirsutism, or biochemically through elevated androgen concentrations in the blood. However, establishing this diagnosis requires a strict process of exclusion. You must rule out other mimics before confirming PCOS. First, you must assess 17-OH progesterone levels to rule out non-classic congenital adrenal hyperplasia. Next, severe systemic endocrinopathies must be excluded, specifically Cushing's syndrome, characterized by hypercortisolism, and hyperprolactinemia. Achieving a precise diagnosis means systematically eliminating these life-threatening mimics. The physician's focus must zoom out from the ovaries to evaluate the entire endocrine system. The invisible engine driving this syndrome is peripheral insulin resistance. This resistance is localized specifically to muscle and adipose tissue, preventing the normal cellular uptake of glucose. When these cells block insulin, the beta cells of the pancreas drastically ramp up their production, creating a state of hyperinsulinemia. This pancreatic overcompensation manages to maintain normal blood glucose levels initially, but it floods the bloodstream with a massive excess of insulin. While the muscle and adipose tissues resist insulin, the ovaries remain fully sensitive to these surges. The endocrine system prioritizes metabolic stability, preserving glucose homeostasis at the expense of the reproductive cycle. That excess insulin bombards the sensitive ovaries, chemically forcing the theca cells to overproduce androgens. Simultaneously, hyperinsulinemia exerts a suppressive action on the liver, dropping the production of sex hormone binding globulin. This globulin, known as SHBG, is the protein responsible for safely binding and transporting sex hormones through the vascular system. The mathematics of this cascade are highly destructive. High ovarian androgen output, combined with a low supply of binding proteins, results in a massive spike of free, biologically active testosterone. Insulin acts as a dual threat. It increases androgen supply at the source while stripping away the proteins meant to keep those androgens bound. These excess-free androgens disrupt the hypothalamic-pituitary-ovarian axis. This disruption leads directly to anovulation and altered, unpredictable menses. The expected laboratory profile will typically reveal an LH to FSH ratio greater than 2, alongside elevated levels of androstenedione and DHEAS. On the surface, this androgen excess produces the classic dermatological signs typical of PCOS patients: seborrhea, acne, and hirsutism. Clinicians must establish the strict boundary between expected PCOS hyperandrogenism and dangerous virilization. In typical PCOS, total testosterone is elevated, but generally stays below 150 nanograms per deciliter. When values exceed 200 nanograms, we cross into a high tumor risk profile. Severe signs of virilization, such as clitoromegaly, a deepening of the voice, and a rapid increase in muscle mass, demand an immediate oncology workup. Understanding these exact androgen thresholds protects the clinician from misdiagnosing a rapidly growing ovarian or adrenal tumor as a routine case of PCOS. Because the etiology relies on a systemic feedback loop, therapy is not curative. It is strictly phenotypic, tailored specifically to the patient's immediate goals. The non-negotiable first-line therapy across all phenotypes is lifestyle modification, diet, and weight loss, aiming directly at breaking the peripheral insulin resistance loop. This clinical flowchart illustrates interventions selected based on the specific phenotypic problem. For menstrual irregularity and hirsutism, treatment utilizes targeted progestogens and oral contraceptives. For severe insulin resistance and metabolic syndrome, the intervention path points to metformin. For patients whose priority is conceiving, clinical focus shifts to ovulation induction, using clomiphene citrate or letrozole. Clinical mastery of PCOS means using your understanding of the pathophysiology to pick the exact pharmacological tool required to fix the specific broken branch of the patient feedback loop. When first-line ovulation induction fails to produce a viable pregnancy, the clinical interventions must escalate. A surgical alternative is laparoscopic ovarian drilling, the targeted thermal destruction of the ovarian stroma designed to artificially lower androgen production. Beyond surgical intervention, in vitro fertilization remains the ultimate and most effective option for overcoming severe anovulatory infertility. Managing this syndrome does not end with a successful pregnancy. The metabolic threat persists as the patient ages. Even after menopause, these patients carry significantly elevated risks for developing type 2 diabetes, dyslipidemia, and severe cardiovascular disease. PCOS is a metabolic condition that requires clinical management for decades, remaining a clinical priority long after a patient's reproductive years have concluded.